Now we'll discuss herniation syndromes. So what is one of the reasons why benign brain tumors or something like hydrocephalus can actually kill people? It's because they increase the intracranial pressure, and this causes herniation of brain tissue into other compartments, resulting in the compression of vital structures, which then leads to coma and or death. Now, hernia is just a general term that is used to describe the protrusion of tissue through an area where it is normally contained. So brain herniation is essentially the same concept as an umbilical hernia or an inguinal hernia. In the brain, there are four areas where the pressure can cause brain herniation. The first we'll discuss is under the falx cerebri. This is called subfalcine herniation. Here's the falx. The most dangerous sequelae of subfalcine herniation is compression of the ACA, which causes frontal lobe infarction. So why the ACA? Well, it's all about the anatomy. So a major trunk of the ACA runs along the rostral caudal axis between the hemispheres just above the corpus callosum. The second we'll mention is transtentorial herniation, when the pressure pushes the brain downward. The brain can either move down centrally, thereby compressing the upper brainstem, which we can see here, or it can move horizontally and compress the medial temporal lobe, which we see in this example here. In central herniation, it compresses the brainstem rostrally to caudally. So, if you look at an atlas, you'll see the structures of the midbrain, and think about the symptoms that could occur. A major portion of the midbrain is devoted to the reticular system, which mediates consciousness and arousal. So, first, the patient becomes confused and drowsy. The nuclei of cranial nerve 3 are in the midbrain, so the pupils become small and react very little. They have doll's eyes, as it were, in quotations, doll's eyes. Later, upper motor neuron signs appear like bilateral Babinski signs, immature reflexes, and decorticate posturing. Eventually, the respiratory centers, which are all the way in the medulla, are damaged, and that is when you have death occurring. The uncus is the medial temporal lobe. So, uncal herniation is the herniation of the uncus into the tentorial opening. Now, when we consider uncal herniation, it's important to think about the anatomy in order to predict the syndrome. The pressure will injure the ipsilateral oculomotor nerve, so there is ipsilateral pupillary dilation. This is the classic presenting sign of uncal herniation, ipsilateral pupillary dilation. The pressure may compress the PCA, so there's infarction of the occipital lobes, which mediates vision. You will also see that the contralateral cerebral peduncle is compressed by the laterally displaced midbrain, so here you would have ipsilateral hemiplegia. Eventually, the pressure crushes the midbrain, leading to vascular occlusion of the arterioles and veins to the brainstem. This is called Durette hemorrhage. Now, once the midbrain and pons are compromised, this is bad news. You have stupor, coma, and respiratory failure. Now, the last herniation we want to talk about is the cerebellar foramen magnum herniation. And this is the downward displacement of the cerebellar tonsils through the foramen magnum, which is here. Think back to Arnold Chiari malformation, which is pretty much the same thing and thus causes the same syndrome. The identifying feature will be paresthesias over the shoulders and loss of deep tendon reflexes in the arms due to compression of the dorsal side of the cervical spinal cord. Also, think about mass effect. The patients will have pain in the neck, a stiff neck. They might develop medullary signs, which will eventually lead to death due to impairment of what? Well, you have to remember that the respiratory centers are found in the medulla. Now, there are a lot of things to remember as you study this material. The best move is to really understand the anatomy. It's so critical. Understand what different regions of the brain do. That will knock out a lot of the guesswork and rote memorization when you get to the pathophysiology and various lesions. Now, of course, the boards will ask you 2, 3, 4-step questions, and many of the neuro questions will require that you identify the problem based on a description of the symptoms. You should feel very comfortable doing this. Now, once you can do that, getting the question right will simply be a function of how diligent you were in your studying. Okay, so our first question. A 74-year-old woman presents with weakness and hyperreflexia of the right arm and leg. Vibratory sensation and proprioception are lost in these areas as well, whereas pinprick and temperature sensation are spared. She does not have facial weakness, but her tongue deviates to the left. Which of the following vessels is most likely involved? Well, the answer here is B, the anterior spinal artery. Okay, so the first thing that you should be able to do is figure out which syndrome the patient has. In this case, it would be medial medullary syndrome. There will likely be questions on exam day that require you to figure out where a patient's stroke is based on a constellation of symptoms. In this case, you should know that contralateral weakness in an upper motor neuron pattern, loss of proprioception and vibration below the neck, and tongue deviation are all signs of medial medullary syndrome. Now, at that point, all you need to do is figure out which vessel usually causes medial medullary syndrome. None of the other choices cause this syndrome. Another commonly tested syndrome is Wallenberg syndrome or lateral medullary syndrome, and this is caused by a stroke in the pica, posterior inferior cerebellar artery. The symptoms here include ataxia, vertigo, hoarseness, loss of pain and temperature in the ipsilateral face and contralateral trunk, and then Horner's syndrome. Remember, this is for Wallenberg or lateral medullary syndrome. Now, in these other answer choices, a stroke in the ACA, that's not it. That would cause visual defects. A stroke in the MCA, that would cause sensory loss and weakness in the contralateral upper extremity and face. So the next question. A 25-year-old man presents to his physician a week after having been involved in a motor vehicle accident. He reports having been sideswiped by another vehicle. However, he claims he never saw the car until it hit him. Now, on neurological examination, you note that he lacks vision bilaterally in the temporal visual fields. Now, in light of this finding, you are concerned that something may be compressing the optic chiasm, resulting in this alteration in the patient's field of vision. Now, which of the following is most likely to be present in this patient's review of symptoms? This patient will likely have D, decreased libido. Okay, so the key parts of this question are to first recognize that the patient has a bilateral hemianopia. Those are the key things there, because it's caused by compression of the optic chiasm. Now, the most likely cause is a tumor in the pituitary gland. So we're going from what are the symptoms telling us? Bitemporal hemianopia. What is the most likely cause of that? A pituitary tumor. And the most common type of pituitary tumor is prolactinoma. As a general rule, when you're answering questions on the boards, if there isn't any evidence to cue you into something different than the most common cause of whatever it is you're looking at, go with the most common cause. Now, excessive prolactin caused by a prolactinoma is what will give you the decreased libido. Now, back pain in a 25-year-old would likely be caused by a musculoskeletal issue and is not a good answer choice for this question. Diarrhea is not a symptom associated with prolactinoma or bitemporal hemianopia. Dysuria is usually seen in a urinary tract infection or some sort of sexually transmitted infection. Lastly, palpitations can have a variety of causes, one being hypothyroidism. Now, this may have been a good choice as TSH is secreted from the pituitary. However, TSH secreting tumors are extremely rare and prolactinomas usually cause suppression of the other hormones, so this would actually lead to hypothyroidism. Okay, so that wraps up the pathology section. I look forward to seeing you guys over in Pharm so we can talk about some drugs.